Greetings, Patho students, and welcome to week 9, which is a review of the endocrine system. This is unit 9 in your ebook, chapters 31, 32, and 33. In addition to this reading on the endocrine system, we have another case study due. This is case study number 4, and it is on diabetes mellitus type 1 with a complication of DKA, and we'll get into this a little bit as I go through the focus. DKA is the hyperglycemic emergency that type 1 diabetics are at risk for. So let's get started with chapter 31, which is entitled Mechanisms of Endocrine Control in your ebook. And this is an overview, reminder basically of what hopefully you have some recall of when you took physiology, the endocrine system. And I don't know what kind of taste in your mouth was left after the endocrine system. Students are often very perplexed. My recommendation is that you look at endocrine disorders as those of hyperfunction of endocrine glands and hypofunction of endocrine glands. And then, depending on your study style, sometimes I recommend just really focusing on the hyperfunction of that gland. And then if you have a clinical picture of what that patient looks like, if you're faced with a question or a scenario where you've got hypofunction, you realize that it's just the opposite. So we'll get into that and see if that makes sense to you. So in chapter 31, the mechanisms of endocrine control, I want you to review the structure and function of the endocrine system. There is a figure 31-1 and table 31-1. The figure shows you all the glands of the endocrine system, starting with the hypothalamus, which is the big chief operator. And table 31-1 goes over the glands, the hormones that are secreted, and then the actions of those hormones. So between that graphic and that table, that'll be a good review for you about all that is included and all that we're addressing in the endocrine system. So going on, remember that it's the hypothalamus that is the CEO, for instance, of the endocrine system. Then there is figure that I want you to look at, figure 31-4, which is the pituitary. Often when I see a diagram or a graphic of the pituitary, it reminds me of testicles. So get over that. You have the anterior pituitary, which is the larger, and when you realize all of the hormones that are secreted, you understand why. And then the posterior, which is the smaller. The posterior basically is responsible for the secretion of ADH, which is antidiuretic hormone, and oxytocin. And all the others come from the anterior pituitary. Growth hormone, ACTH, adrenal corticotropic hormone, which works on the adrenals. TSH, thyroid stimulating hormone. FSH, follicle stimulating hormone, and LH, those last two related to reproductive function. In this section, we review the mechanisms of regulation of hormone levels. Most of the endocrine system, most of the glands in the endocrine system, we say, operate by way of a negative feedback system. And think about a thermostat. When the hormone level drops below a certain level, that serves as a stimulation to produce more of that hormone. A few of the glands work by way of positive feedback. And there's a couple of exceptions where the hormones actually have an impact on, or a target on, something other than hormone level, and insulin is an example of that. So that increased levels of insulin would reduce blood glucose levels. Increased levels of aldosterone might have an effect on sodium and potassium levels in the blood, for instance. Moving on to look at what are the diagnostic tests we use to evaluate the endocrine system and its function. We look at certain blood tests that I'd like you to read about, certain blood tests, certain urine tests, And then the idea of stimulation and suppression tests. We don't do these very often. They're a little bit complex and they require some timing and some specific intervention by the nurse usually. There are some exams where we want to stimulate a certain endocrine gland and see what the response is, or if it does respond. And then there's others where we want to suppress and then see what the response is to that. And that really helps typically with the diagnosis of the issue. So moving on to chapter 32, this is the disorders of the endocrine control of growth and metabolism. So again, we're looking at hypofunction of the endocrine system, hyperfunction of the endocrine system. And here we're going to differentiate between primary, secondary, and tertiary. The easiest way to remember this is the way I remember it, hopefully it'll help you, is for instance, primary adrenal disorder means that the issue is in the adrenals itself. There is possibly an adrenal tumor or some other situation with the adrenal gland itself. Secondary would be, for instance, if we're talking about the adrenal example, the adrenals are functioning totally fine, and yet there is hyper or hypofunction as a result of the messenger hormone, which is ACTH, which comes down from the pituitary, either under stimulation of the adrenals because of lack of ACTH or overstimulation of the adrenals because of excess ACTH. But yet we still have perfectly healthy adrenals, but we have a problem with the pituitary. I keep pointing up in the head, a pituitary up in the head. Could be a pituitary tumor that's responsible. So we call that secondary. Our adrenals are healthy, but they are misperforming as a result of the messenger that's just knocking on the door, telling it what to do. It's obeying its command, but it results in dysfunction. And then tertiary, far less common, is a problem or dysfunction with the hypothalamus itself, where both the pituitary and the target organs are being understimulated. So that obviously is going to affect many organs, not just like in my example of the adrenals. And as I say, far less common. So in general, we're talking about a primary disorder. Same thing can happen with thyroid, a primary or a secondary disorder. So as you continue reading in chapter 32, it's going to be a review of the pituitary hormones, which we already looked at in the previous chapter, recalling that it's the anterior pituitary that's responsible for most of our endocrine hormones, and then the posterior pituitary responsible for ADH and oxytocin only. So you can go down through this chapter till you get to growth hormone. So for growth hormone, I'd like you to look at childhood and adult examples of too much growth hormone and abundance of growth hormone. We call this acromegaly. So you'll see examples in figure 32-3 of childhood example, and figure 32-4 of adult example of acromegaly. So look at what the causes and the effects of acromegaly or too much growth hormone would be. Moving on to thyroid hormones and thyroid hormone disorders. Again, we're talking about hypothyroidism, underperformance, inadequate function, hyperthyroid, overstimulation or overfunction. And there is a great clinical picture again of a patient, 32-9, a clinical presentation of hypothyroid, and 32-10 presentation of hyperthyroid. Get those pictures in your head because you'll see how many body systems are affected by the underperforming and the overperforming thyroid. There's also a graphic of goiter. Goiters, they're in every textbook because they're just so kind of gross and just interesting to look at. You don't see them very often, but know that you might just look at that and think, oh, that's a hyperactive Thyroid. A patient can have a goiter with the hyper and the hypo state of dysfunction. So it's interesting, and you can see how, depending on the progression of the goiter, how it could impact circulation, and it could certainly impact airway maintenance. So moving on to, of the disorders of the thyroid, I'd like you to look at Graves' disease, which is an autoimmune presentation which results in hyperfunction of the thyroid, and also thyroid storm, thyroid crisis. By its name, you get the idea that it also is a function of hyperthyroid. And typically, maybe not typically, but it's common enough to see thyroid storm post-thyroidectomy, either in the operating room or in the PACU area, the recovery area, where the thyroid has actually been removed. Possibly there's a tumor. But in the manipulation of the thyroid, there is a surge of thyroid hormone that's released into the bloodstream. It has a really drastic and profound effect, and it can affect the patient's vital signs, and it is considered a crisis. So read about that and what intervention we use to settle that patient down after an episode of thyroid storm. Moving on to the adrenals. The adrenal cortex and the hormones of the adrenal cortex. My memory tool here is the 3 S's: sugar, salt, and sex. So the sugar hormone related to the adrenal cortex is cortisol. The salt hormone, the major mineral corticosteroid released by the adrenal cortex, is aldosterone. And then the S stands for sex. Those would be sex hormones also released by the adrenal cortex. So I do want you to look at cortisol. There's a table that talks about the effects of cortisol. Know that increased levels of cortisol, we think of cortisol as a stress hormone, but there's a great graphic that basically talks about all the influences on the hypothalamus that can result in increased stimulation of the adrenal cortex that can result in too much cortisol. And the biggest problem with cortisol is that it suppresses our immune system. Obviously, it's going to increase our blood glucose, but it also suppresses our immune response, which is not a good thing. So read about that. And again, with the emphasis on cortisol, you'll see that related to glucose in that table 32-2, which talks specifically about cortisol, one of the things it does is it increases gluconeogenesis. Gluconeogenesis occurs in the liver. Gluconeogenesis, neo. So the new manufacture of glucose. Neogenesis means in most cases it's coming from amino acids, stored amino acids or proteins. It also, increased cortisol also decreases the glucose uptake by tissue. So again, the result is going to be increase of circulating blood sugar, not a good thing. Back to primary and secondary. My example that I gave you earlier was with the adrenals, so you'll read about the difference between primary adrenal cortical insufficiency and secondary adrenal cortical insufficiency. Look at table 32-3. Here are two primary disorders: are Addison's disease, which is the hypofunction of the adrenals, and Cushing's disease or Cushing's syndrome, which is the hyperfunction of the adrenals. 32, 15, 16, and 17 give you some clinical pictures of that. Moving on to chapter 33, diabetes and metabolic syndrome. So you'll start with the incidence of diabetes in the United States, and you'll see numbers in the millions. Know that most of those patients are, we talk about, well, I think the chapter actually talks about 4 kinds of diabetes. We really talk about three, which are type 1, type 2, and then gestational diabetes, which is temporary. Type 1 diabetes is an absolute absence of insulin. Problems with the islets of Langerhans in the pancreas, which are responsible for the production of insulin, where this patient, usually diagnosed in childhood, but occasionally diagnosed as an adult, we now know that diabetes type 1 is an autoimmune disorder. So the patient might have a predisposition for it in the family or whatever, and there may be a viral infection that might seem insignificant, but the result is it triggers this autoimmune response, which leaves the patient unable to produce insulin. A type 1 diabetic is what we call an insulin-dependent diabetic. They will be taking insulin for their entire life. Whereas a type 2 diabetic, later in the chapter, it actually, if you go to chart 33-1, gives you an overview of metabolic syndrome. Many type 2 diabetics, the metabolic syndrome is a precursor in many cases for diabetes type 2. A diabetes type 2 patient manufactures insufficient insulin. Their pancreas is still making insulin, but it is not adequate to keep up with the demand of the amount of glucose that is circulating for this patient. And of course, you'll read about type 2 diabetics, and I call this a lifestyle disorder. It's, in many cases, it can be reversed. So if you're, let's say if you're in your 30s or 40s and you're diagnosed with type 2 diabetes, I'm thinking you're probably overweight, although not always. I had one student who just jumped down my throat once, said he had a relative with type 2 diabetes who was not overweight. A sedentary lifestyle, overweight, poor diet, there's other risk factors involved. That if you take on these lifestyle changes within a year or two, say you lose 20 or 30 pounds, you can come off of medication and you no longer have any signs or symptoms of type 2 diabetes. Unfortunately, behavior change is not as easy as it sounds, and it's not something that we're all necessarily good at. But keep this in the back of your head when it comes to type 2 diabetes. There are some countries that do not know what type diabetes is. So that kind of tells you this is a lifestyle situation. Although I'm not here to say that it's easy to change behavior. I'm the first one to say that it's very difficult. And we're talking about lifelong changes in behavior, because it's probably been lifelong up to whatever your age of diagnosis, 30 or 40 years old. However, these days we're seeing more and more teenage type 2 diabetics, which is tragic. Tragic. Put away the video games, get out in front of the computer, get outside, play baseball, do something, run around, play tag. As I say, this is lifestyle. That's type 2 diabetes, and we'll talk about what the complications of both of these. So you have your alpha and beta cells in the islets of Langerhans, and so I want you to know that one is responsible for the manufacture of insulin. I'd also like you to read what are the 3 functions of insulin. What are the 3 distinct things that insulin does for us? Also responsible for the manufacture of glucagon in the pancreas. It is glucagon that initiates glycogenolysis. Glycogenolysis. So glycogen lysis. So we have stored in our liver glycogen. If we think about insulin and glucagon as partners in crime, insulin works to decrease blood glucose by escorting that blood glucose into the cell, leaving the bloodstream, going into the cells. It really does no good for us in the bloodstream. Glycogen, on the other hand, works to increase blood glucose when we need it. So when our blood glucose level falls below, many texts say below 70, some say 60, but let's call it 70. It is glucagon that is going to start initiates this glycogenolysis, lysis of the glycogen, which is stored glucose in the liver, to help bring our blood sugar up, because obviously we don't want to become hypoglycemic. The other thing that glucagon does for us is it assists with gluconeogenesis, also happening in the liver. New, making new glucose out of stored amino acids and fats. So glycogenolysis is the lysis of stored glycogen. The result is increased blood glucose. Gluconeogenesis is converting amino acids and fats into glucose when we need it. So there is an excellent video in this chapter on diabetes. So find it. It's in the middle of your chapter, and it's about six or 6.5 minutes long. It goes over the different types of diabetes, and it shows in the bloodstream exactly what's happening when the blood sugar goes up and what the effects of insulin are. Also refer to table 33-2 for the different types of diabetes. As I say, type 1, type 2, and gestational are what we focus on. Going on, read about metabolic syndrome and realize that is a precursor to diabetes type 2. Also in the video, it'll go over what some of the reading does about the signs and symptoms of hyperglycemia or diabetes if it's not yet been diagnosed, which are polyuria, polydipsia, and polyphagia. Moving on in your reading, you'll read about, for type 2 diabetics, what are the effects of diet and exercise. And basically, appropriate diet is going to be very helpful. And then exercise will actually decrease your need for insulin. In figure 33-8 and 33-9, it goes over the injectable meds and the oral meds. So we already said that type 1 diabetics are going to be reliant on insulin, injectable insulin. Now, some patients will move on to a continuous injection of insulin or an insulin pump. But in this area, you're going to read about the 4 different kinds of insulin. We have short-acting, which we know as regular insulin. We have rapid-acting, usually we call that Lispro. And then we have intermediate-acting and long-acting. So when you have patients in the hospital that are getting meal coverage for their insulin, we will take a blood sugar test right prior to eating each meal, and based on a table that's been prescribed by their doctor, we're going to give them X amount of rapid-acting insulin to cover the carbohydrates that they're going to intake for that meal. So we want to avoid a patient from spikes and drops in their blood sugar. It's best to keep their blood sugar on an even keel within a healthy blood sugar level or serum glucose level. Moving on to the complications of diabetes and the treatment of those complications. So I mentioned diabetic ketoacidosis. So basically our complications our acute complications come in 2 categories. One is the hyperglycemic emergency state. For diabetes type 1 patients, that is called diabetic ketoacidosis, or DKA. For diabetes type 2 patients, their hyperglycemic emergency is called hyperosmolar hyperglycemic state, or some texts call it HHNS, which is hyperglycemic hyperosmolar non-ketotic state. The big differentiation between the two is that because diabetic type 2s do produce some insulin, that protects them from going into acidosis for the most part. So the main difference is that they are not producing ketones. That is one diagnostic factor we use to differentiate the two. A type 1 diabetic in DKA will be spilling ketones into the urine, where that is not the case for a type 2 diabetic in a hyperglycemic state. Both categories of diabetics, type 1 and type 2, can experience hypoglycemic emergencies. Obviously, in those cases, our goal is to bring their blood sugar back up to a normal level. Those are the acute complications. So it's going to be too much or too little blood glucose. The chronic complications of diabetes are many. We have microvascular disorders, macrovascular disorders, and then foot ulcers. And basically figure 33-11 gives you an overview of all of the different complications that come from the chronic complications from a patient with diabetes. If you'll recall 2 weeks ago that we talked about kidney disease, chronic and acute. Chronic kidney disease, the primary cause of chronic kidney disease is diabetes. Diabetes and then hypertension. Second in line is hypertension. If you imagine that, this is what I tell students to imagine, that blood glucose, the glucose that is circulating in your blood, think of it as snowflakes. I mean, snowflakes are beautiful, but they have jagged edges. So when you have too much blood glucose, you are actually doing microvascular damage throughout your whole body. And then the effects of that sometimes move into what we call macrovascular. And so the microvascular, one example is kidney disease. So it is basically shearing off those, I say it's shearing off the walls of the nephrons. I don't know that that's exactly what's happening, but it's an easy way to remember that high levels of blood glucose constantly are going to have a negative impact on the actual renal tissue, and it causes the demise of many of those nephrons. Remember, we have 1 million and 1 million in each kidney, 1 million, but a diabetic can, by the time they're in their 50s, they can find themselves on dialysis if they have not been prudent in managing their diabetes and keeping their blood glucose levels in check. So look at that figure 33-1. Some of the other microvascular damages that happen in the eye, which is why some diabetic patients go blind because of the retinopathy that is a result of blood sugars being too high. The macrovascular, that is cerebral vascular problems and cardiovascular problems. It is a precursor for coronary artery disease if you do not attend to your blood sugar levels. And I'm saying attend, take care of, be astute in caring of. Keep in mind that there's lots of people out there who are undiagnosed. They don't even know that their blood sugar levels are too high. Then what we do see in the hospital very often is the foot ulcers. So you're going to read about both the nephropathies. You might think it's a misprint in your book. Diabetic nephropathies, which has to do with loss of nerve function in the periphery. It's usually in the periphery. So when we say foot ulcers, what is the most distant appendage you have? It's your feet. And as the circulation breaks down, you get poor circulation, but you also get loss of sensation. So you'll have neuropathies in your feet and legs. Then with the microvascular dysfunction in the periphery, you get poor circulation. And that's how the foot ulcers develop, and that's how then you have patients first having toes amputated, then feet amputated, then below the knee amputated, sometimes above the knee amputated. And once a diabetic has undergone one amputation, their chances for subsequent amputations raise enormously. So that's just unfortunate. But there is intervention that can help with that, but it does take someone paying attention and managing their disease. So we have those neuropathies and poor circulation problems. Then also there's a section on the kidney issues, which is called diabetic nephropathy, nephro for the kidneys, nephropathies. So we mentioned the neuropathies, the nephropathies, the retinopathy, all chronic side effects of basically too much sugar, hyperglycemic problems. And then we're left with the very final chronic problem for diabetics is a increase in risk for infection. So say a diabetic comes in to have their appendix taken out, because obviously any health problem can befall a patient and they happen to have diabetes. So they may have a small incision, and because of their diabetes, their wound healing is impaired. Their healing is going to take a longer period of time. As we protract that period of healing, the patient has an increased risk for infection until that primary healing is in place. So if you or I have an appendectomy, we'd expect to heal fairly quickly and not have an issue. But a diabetic patient has an increased risk for infection. They have a decrease in their immune response and increased risk for other post-surgical complications. So it's a pretty sad picture, although for many patients there is intervention that can help prevent these problems. So that concludes our overview of our reading for week 9. Recall that you do have a case study due, and recall that at the end of week 9 you should be ready to take your course exam 3, which you will find back in the point uploaded for you in PrepU as course exam number 3. If you have any questions about the case study or about the exam, please do drop me an email, and pay attention to your calendar so you know when the exam opens and when it closes. I cannot stress that enough. That is your responsibility to heed the calendar and act accordingly. Thanks a lot. We'll see you next week.